More than 154,000 Americans have a diabetes-related leg or foot amputation every year. But here's what most people miss. 85% of those could have been prevented if they'd noticed these 9 warning signs that show up in your feet long before a doctor ever tells you that you have diabetes. 40.1 million Americans carry this disease right now, and 11 million of them have never been diagnosed, which means more than 1 in 4 people with diabetes are completely unaware. That data comes straight from the CDC National Diabetes Statistics Report, updated January 2026 using 2023 numbers. Among Americans 65 and older, 28.8% already have diabetes, and another 52.1% have prediabetes. When you add those figures together, the vast majority of seniors in this country are dealing with blood sugar problems at some level. Your feet tend to be the first place those problems announce themselves. Before the blurry vision, before the unquenchable thirst, before any formal diagnosis, nerve damage and circulation issues can start showing up between your toes and along your soles. And ignoring those early signals carries a steep cost. People with diabetes account for 80% of all non-traumatic lower limb amputations across the country. But here's the thing. The American Diabetes Association reports that up to 85% of those amputations could have been avoided with early detection and proper foot care. Over the next 20 minutes, we are going through all 9 warning signs, breaking down the biology behind each one, presenting the statistics, and explaining when each sign typically develops. If you are over 60, or if you look after someone who is, this information could protect a limb and quite possibly extend a life. We start with the single most common foot complication of diabetes. Sign 1. Numbness and tingling in the feet. Numbness or tingling in the feet, a condition called peripheral neuropathy, ranks as the first and most widespread warning sign. The damage begins at a cellular level through what's known as the polyol pathway. Chronically elevated blood sugar floods nerve cells with glucose, which gets converted into sorbitol, and that conversion creates osmotic stress inside the cell. Proteins throughout the nerve structure accumulate what scientists call advanced glycation end products, and those deposits degrade the nerve fiber over time. Inflammation ramps up, oxidative stress compounds the problem, and the tiny blood vessels feeding the nerves, known as the vasa nervorum, start to break down. Because the longest nerves suffer first, symptoms almost always begin in the feet and climb upward in what doctors describe as a stocking and glove pattern. 28% of people with diabetes have peripheral neuropathy at any given time, and the lifetime risk sits around 50%. That means roughly half of all diabetics will eventually deal with nerve damage in their feet. Among type 2 diabetics over the age of 60, the rate exceeds 50%, up dramatically from 5% in people aged 20 to 29. What catches many patients off guard is that 10 to 15% of people newly diagnosed with type 2 diabetes already show signs of neuropathy at the moment of diagnosis. Nerve damage had been building for years without detection. The PROMISE cohort study published in Diabetes Care found that 49% of people with prediabetes had peripheral neuropathy, which was nearly identical to the 50% found in new-onset diabetes patients. When it comes to red flags, watch for any new or worsening numbness, the inability to sense temperature shifts or pain, and not feeling a cut or sore on your foot. Neuropathy increases the risk of developing a foot ulcer by roughly 7-fold, according to the American Diabetes Association. That leads directly into the painful counterpart of nerve damage. Sign 2. Burning or shooting pain in the feet. Burning, shooting, or stabbing pain in the feet, particularly at night, points to painful diabetic neuropathy. Where standard neuropathy targets larger nerve fibers, the painful version attacks the small ones, specifically the unmyelinated C fibers and thinly myelinated A delta fibers responsible for transmitting pain and temperature. Damaged small fibers do not simply go quiet. They begin firing spontaneously, becoming hypersensitive, generating sensations that patients often describe as burning, electric shocks, or stabbing that ranks among the worst pain they have experienced. About 25% of all people with diabetes develop painful neuropathy. Among those who already have peripheral neuropathy, the proportion climbs to nearly half, with a global meta-analysis placing the pooled prevalence at 46.7%. One detail sounds contradictory but carries real clinical weight. Pain can actually fade in very advanced neuropathy as the nerve fibers die off completely. A patient whose chronic burning suddenly vanishes should not interpret that as improvement, because the silence may mean the nerves have deteriorated beyond the point of transmitting any signal at all. Red flags for this sign include persistent burning or stabbing sensations, pain severe enough to disrupt sleep, extreme sensitivity where even bed sheets touching your feet triggers discomfort, a condition doctors call allodynia, and any abrupt shift in the character of your pain. Both numbness and pain trace back to nerve damage, but the next sign reveals what happens when you combine that nerve damage with another problem diabetes creates. Sign 3. Slow healing wounds or sores. Any cut, sore, or blister on the foot that refuses to heal normally opens the door to one of the most dangerous complications in diabetes, the diabetic foot ulcer. Diabetes undermines wound healing through at least 7 overlapping pathways. White blood cells lose effectiveness because high blood sugar hampers immune function. Tiny blood vessels deteriorate, delivering less oxygen to injured tissue. New vessel formation, a process called angiogenesis, slows down. Immune cells become trapped in a pro-inflammatory state, stalling the transition to actual repair. Collagen production drops. Free radicals pile up and damage surrounding tissue. And neuropathy means the original injury may go completely unnoticed for days or weeks. Lifetime risk of a diabetic foot ulcer falls between 19 and 34%. North America carries the highest regional prevalence rate at 13%, and roughly 1.6 million Americans contend with a foot ulcer in any given year. Once an ulcer forms, 50 to 60% become infected, and about 20% of moderate to severe infections end in amputation. Doctors classify these ulcers using the Wagner classification system, which grades severity from superficial wounds to deep infections involving bone. The mortality numbers reframe this as something far more serious. 5-year mortality for diabetic foot ulcer patients sits at approximately 30%. After a major amputation, that figure exceeds 70%. Researchers at the University of Southern California have noted that the 5-year mortality following limb amputation reaches 68%, second only to lung cancer at 86%. Dr. David Armstrong described the comparison directly when he wrote that ulcers have been compared with cancer. The financial weight matches the medical severity. Diabetic foot complications consume $9 to $13 billion per year in direct costs. Medicare beneficiaries with a foot ulcer run up roughly $33,000 annually in total costs, and those with an amputation average $52,000. Recurrence adds another layer of difficulty, with 42% of ulcers returning within 1 year and 65% returning within 5 years, which is why researchers now prefer the word remission over healed. Watch for any cut, sore, or blister showing no improvement after 1 to 2 weeks. Any signs of infection such as redness, warmth, swelling, drainage, or odor, and any foot wound you do not recall injuring. 85% of all diabetes-related amputations trace back to a foot ulcer that came first. The next sign requires nothing more than looking down. Sign 4. Changes in skin color. Skin color changes on the feet and lower legs can reflect several different conditions happening at once. Acanthosis nigricans produces dark, velvety patches where excess insulin stimulates skin cell growth. When the body becomes insulin resistant, it compensates by producing more insulin, and that surplus activates receptors that thicken and darken the skin. What makes this sign especially telling is its timing. Acanthosis nigricans can appear during prediabetes, making it one of the earliest visible markers of metabolic dysfunction. The ADA recognized this in 2000. Diabetic dermopathy, sometimes called shin spots, produces light brown or reddish patches from damaged capillaries that deposit hemosiderin and melanin. This condition stands as the most common skin manifestation of diabetes, present in 30 to 50% of patients. Poor circulation introduces a third pattern, pale, bluish, or purplish discoloration, particularly in the feet. Across all types, skin disorders affect nearly 80% of people with diabetes. New darkened, velvety skin patches deserve immediate attention. Changes in foot skin tone toward pale or blue warrant a visit to your doctor. Persistent redness and warmth concentrated in just one foot could signal infection or Charcot foot. The fifth sign is one many write off as getting older. Sign 5. Swelling in feet and ankles. Swollen feet and ankles in a person with diabetes can stem from multiple causes. Damaged capillary and vein linings allow more fluid to seep into surrounding tissue. Weakened vein valves let fluid pool in the lower legs. Diabetic kidney disease reduces the body's ability to filter fluid. Heart failure, more common among diabetics, backs fluid up into the extremities. Autonomic neuropathy disrupts microvascular blood flow. Certain medications like calcium channel blockers or insulin itself can also promote fluid retention. Pay attention to sudden swelling. Pitting edema, where pressing on skin leaves a lasting dent, warrants evaluation. Swelling paired with shortness of breath is serious. None of these deserve a shrug. All of them deserve a conversation with your doctor. Now for a warning sign so common most never connect it to diabetes at all. Sign 6. Dry, cracked skin on feet. Excessively dry, cracked skin on the feet, particularly the heels. Looks like a cosmetic nuisance, but in diabetes the cause is neurological. Autonomic neuropathy damages the nerves controlling sweat glands in the feet, a process called pseudomotor dysfunction. When those nerves fail, the feet lose their natural moisture source, sweat, and the skin becomes dry, stiff, and prone to splitting. What gives this sign extra diagnostic value is that pseudomotor dysfunction ranks among the earliest detectable abnormalities in small fiber neuropathy. It can surface during prediabetes, well before other symptoms emerge, which means persistently dry feet could function as an early alarm. Xerosis, the clinical term for dry skin, appears in 26 to 69% of diabetic patients depending on the study. One investigation recorded it in 69% of participants. Those cracks running through your heels and between your toes are not just uncomfortable. Each one serves as an open doorway for bacteria and fungi. For someone whose immune defenses are already weakened, a single heel crack can become the starting point for infection, then an ulcer, and then something far worse. Watch for deep fissures in the heels or between the toes, bleeding or infected-looking skin, and dryness that persists despite daily moisturizing. That damaged, cracked skin sets the stage perfectly for the 7th warning sign. Sign 7. Fungal infections. Recurring toenail fungus in athlete's foot show up far more often in people with diabetes, and the reasons trace back to several factors. Elevated blood sugar weakens the frontline immune cells, neutrophils, and phagocytes that normally keep fungal growth in check. High glucose levels also create a nutrient-rich environment that fungi exploit. Impaired microcirculation means fewer immune cells reach the site. A systematic review published in the journal Mycoses found onychomycosis in approximately 29 to 31.5% of diabetic patients. That rate runs roughly 3 times higher than the general population. Onychomycosis alone accounts for nearly 50% of all nail disorders. Dismissing a discolored toenail as harmless overlooks a real risk. A yellowed nail can be the first link in a chain that ends with limb loss. Red flags include thickened, discolored, crumbly, or brittle toenails and any fungal infection that returns after treatment. From infection risk, we shift to a sign that is entirely about blood flow. Sign 8. Cold feet and poor circulation. Feet that feel cold or look pale or bluish all point toward peripheral arterial disease or PAD, a condition that diabetes accelerates dramatically. High blood sugar damages the inner lining of blood vessels, triggering chronic vascular inflammation that promotes plaque buildup. Abnormal cholesterol levels common in diabetes compound the problem. Platelets become stickier, and the body's clot-dissolving system weakens. What distinguishes diabetes-related PAD is its location. It tends to produce severe disease below the knee, targeting the tibial and peroneal arteries. PAD prevalence among type 2 diabetes patients ranges from 15 to 40%, dwarfing the general population rate of about 5%. The UK prospective diabetes study tracked prevalence from 1.2% at diagnosis to 12.5% after 18 years. The American Diabetes Association recommends an ankle brachial index screening test for all diabetic patients over 50. Watch for feet that feel noticeably colder than the rest of your body, or leg pain while walking that goes away with rest. Left unchecked, severe PAD advances to critical limb-threatening ischemia, gangrene, and amputation. The final warning sign is rare, but missing it carries devastating consequences. Sign 9. Changes in foot shape. A visible change in the shape of your foot signals one of the most destructive complications, Charcot-neuroarthropathy, or Charcot foot. This condition amounts to a progressive destruction of the bones and joints, set in motion by a cascade that peripheral neuropathy triggers. Without the ability to feel pain, stress fractures go undetected. The arch of the foot can collapse into what doctors call a rocker bottom deformity. The American Academy of Orthopedic Surgeons warns of a 50% amputation risk if an ulcer develops on top of the deformity. Motor neuropathy causes muscle wasting and imbalances. Hammer toes, claw toes, and bunions develop as a result, creating new zones vulnerable to breakdown. Charcot foot remains uncommon, affecting 0.1 to 0.56% of patients. Among those with neuropathy, the rate climbs to 1 to 2%. Recognizing the acute phase is critical. Look for a red, hot, swollen foot, typically on one side only, that may cause little or no pain. One clinical clue is that elevating the foot reduces Charcot-related swelling, but not swelling from infection. Any new deformity warrants urgent attention. All 9 warning signs are now on the table, from tingling and numbness through burning pain, slow healing wounds, skin color shifts, swelling, cracked skin, fungal infections, cold feet, and structural changes in the foot itself. The question now is what to do with all of this. Every major guideline body, the ADA, the CDC, the International Working Group on the Diabetic Foot, and the American Podiatric Medical Association, converges on the same set of core actions. Check your feet every single day. The CDC frames it simply. Check your feet every day, even if they feel fine. That second part matters because nearly half of people with peripheral neuropathy experience no symptoms whatsoever. Examine the tops, bottoms, sides, and heels of both feet and look between every toe for cuts, blisters, redness, swelling, calluses, warmth, or color changes. An unbreakable hand mirror helps you see the soles, and asking a family member to assist works just as well. For those managing diabetes, continuous glucose monitors can help track how blood sugar spikes might correlate with worsening foot symptoms, providing valuable data for your healthcare team. Schedule a comprehensive foot exam at least once a year with a board-certified podiatrist or diabetic foot specialist. The ADA calls for annual comprehensive foot examinations for all people with diabetes, with more frequent checks for those at elevated risk. One standard component of that exam is the 10-gram monofilament test, where a nylon fiber gets pressed against 4 sites on each foot until it buckles, delivering exactly 10 grams of force. With your eyes closed, you report whether you felt the touch, and the test carries a sensitivity of 57 to 93% with a specificity of 75 to 100%. The ADA 2026 Standards of Care also recognize a newer method called the Ipswich Touch Test, where the doctor touches the tips of your toes with a fingertip for 1 to 2 seconds, useful when instruments are not available. Act on any changes immediately. Non-healing wounds, new numbness or tingling, temperature or color shifts, new deformities, drainage, and odor all warrant a same-day call to your doctor. One statistic pulls all of this together. The American Podiatric Medical Association states that including a podiatrist in your diabetes care can cut the risk of lower limb amputation by up to 85% and lower the risk of hospitalization by 24%. We began with a single number: 11 million Americans living with undiagnosed diabetes. More than 1 in 4 people with the disease have no idea they carry it, and their feet may already be sending distress signals. Numbness and tingling, burning or shooting pain, wounds that will not close, skin color changes, swelling, dry, cracked heels, fungal infections, cold feet with poor circulation, changes in foot shape. Some of these signs are subtle: a toenail that looks different, a slight tingle at night, dry skin that never quite resolves. Others represent an emergency, like a red-hot, swollen foot signaling an acute Charcot episode or a wound that deepens by the day. One finding from the research stands above the rest. Painless neuropathy poses a greater threat than painful neuropathy. Feeling nothing in your feet does not mean nothing is wrong. Dr. David Armstrong captured it when he described how patients with painless neuropathy lose the gift of pain and wear a hole in their foot the same way you would wear a hole in your shoe. And yet, even against those stakes, the evidence confirms that early detection combined with consistent foot care prevents the vast majority of catastrophic outcomes. Recent studies have shown that SGLT2 inhibitors like Jardiance or Farxiga can reduce amputation risk in certain high-risk patients, adding another tool to prevention strategies alongside traditional approaches. Looking at your feet every day, seeing a board-certified podiatrist at least once a year, and acting at the first sign of trouble count among the most powerful things you can do to protect your health after 60. If anything in this video matched something you have noticed in your own feet or in the feet of someone you care for, do not put this off. Talk to your doctor. Get your feet examined. A 20-minute appointment could redirect the rest of your life. Thank you for watching. Share this with someone who needs to hear it, and subscribe for more evidence-based health information designed with you in mind. Take care of yourselves, and take care of your feet.